going to start recording. That's it.
Okay, let's start then. Welcome everybody once again to the seminar of the Special COVID Project on Mathematical Modeling of the National University of Mexico. We welcome you all, and it is really indeed a great pleasure and an honor to have with us this afternoon Dr. Jane Heffernan. She is a professor in the Department of Mathematics and Statistics at York University in Canada, where she is a York Research Chair. She is also the director of the Center for Disease Modeling, a very important disease modeling center in Canada and in the world. And he belongs to the board of directors of the Canadian Applied and Industrial Mathematics Society. We thank very much Jane, not only because she will give us a talk about her research, but also because she's on sabbatical in France, and in France is 7 hours ahead of us. So she's at midnight and working with us. We really appreciate this effort. And without more saying, the only thing I have to say because of the protocol is that this is a seminar, academic seminar. The opinions of the speaker are her own and do not necessarily represent the point of view of the project of the National University of Mexico. And the discussion has to be an academic one and related to the work we're doing on COVID. So without more saying, please, Jane, the screen is yours. Thank you very much.
Thank you very much for the kind introduction and the kind invitation for this seminar. I'm going to, as Jorge just said, that usually I'm located at York University in Toronto. Currently I'm on sabbatical and I'm actually located in the COVID-19 hotspot right now, which is in Bordeaux in France. So we are experiencing very different environment compared to back in Canada. However, the environment is actually less strict than I was experiencing back in Canada, which is interesting considering the numbers of cases that we're getting every day here. So it's an interesting experience. So today I'm going to discuss some of the work that I've been doing with Matt Betty, who is an assistant professor at Mount Allison University, which is also in Canada. Matt and I have been doing a lot of work on trying to model healthcare demand and personal protective equipment. So it's like N95 masks and surgical masks and gowns and things like that within the healthcare sector. So I'll give you an overview of what we've been doing. There's not a lot of math in this talk, so hopefully that is okay with you. And then I'll give you at the end a little bit of an idea of things that we're pursuing with extensions to this work. So in terms of what we're doing here, in order to actually provide good projections for personal protective equipment, we actually need to know what our projections are going to be for COVID-19 cases. And so what we do first is we actually run an epidemiological model. And then what we do is after we get all the data from the epidemiological model, then we flow all of that data through a healthcare demand model so that we get an idea of how many people are in hospital and how many people are going to the doctor. And then once we know all of that information, then we can calculate what our masks and gowns and gloves, et cetera, will be. And so let's go back. So we have a 3-module workflow. And so the first thing that we do is we are using 2 different types of epidemiological models. The first one is scenario-based, and it incorporates contact tracing, as well as social distancing and self-isolation. I'll give more detail when we get to those slides, and school closure. And it also incorporates age structure and more items within a population strata. We also have a simple model that we've been using to fit to known cases. And we use this to fit to not just known cases, but maybe also hospitalization and death data, which we can then use to project what the epidemiological situation will be for different provinces in Canada and territories. And then we can generate what the personal protective equipment needs will be within those jurisdictions. So once we have the cases or the known cases, the testing, you think all the people that once you know a case, then maybe they'll go to hospital, etc. Then what we do is we try to determine where these cases are going to go within the healthcare setting. And so we incorporate different settings within the healthcare demand. So we look at GP offices, which are general practitioners, which is just like your family doctor, emergency departments, and we also incorporate assessment clinics, which is where people would go, just like testing clinics. So there's those three components. We may or may not include clinics. It depends on the province and what the public health protocols are being practiced. And then we also incorporate within the hospital setting, we incorporate ward beds and ICU beds. So we can do more, we're extending to look at long-term care facilities. So for our elderly population, we can also extend to social workers. We can extend to many different things, even schools and government buildings, etc. So within each jurisdiction, though, for what I'm going to talk about today, there is data that we need. And so these include the number of beds per jurisdiction within the wards and the ICUs, the number of general practitioners, the number of emergency doctors. And then we also have to determine when we have assessment clinics, because these aren't an everyday thing within the healthcare system, we need to determine how many of the GPs and how many of the emergency doctors are going to be manning the assessment clinics, so that we draw doctors away from some things so that we can put them into the assessment clinic jobs. So within that, we also have data that we require, like length of stay if someone goes into the hospital, whether they're in the ward bed or the ICU, that depends, whether they're switching between the ward and the ICU and back and forth. We look at admission rates for severe and mild cases and a bunch of other things, which I'll get into a little bit later. And then once we know where all of the COVID-19 patients are going, then we can determine what our personal protective equipment needs are going to look like. In each one of these settings, our personal protective equipment set is different. And so what we can do is we can project what the sets, how many sets are going to be needed depending on what the healthcare setting is, and not just looking at what the doctors and nurses are going to need to use, but also looking at all the background workers as well. So like the receptionists and the cleaners and things and people like that. So we look at the background use for personal protective equipment. We calculate the PPE per case, and then we project what the needs are going to be depending on whether the use is in a conservation type of mode versus a moderate use mode or versus a per touch point mode. And we can also incorporate whether the personal protective equipment is going to be recycled and how often it's spoiled. So within the first, so I'm now going to go and look at the EPI models. So I should mention that this workflow was first developed by colleagues at the University of Melbourne. And we were asked if we could adopt this code by the Public Health Agency of Canada, if we could adopt this code from the Australian context over to the Canadian context. And the people in Australia that have developed this code are actually people that I visited on my last sabbatical. And so having that experience with working with them, I was best adapted to working with this code to adapt over to the Canadian setting. So the first thing that we do within this framework is we look at the EPI scenarios. And this is a scenario-based model where what we're doing is we're taking the susceptible class, and then we are contact tracing all known or all infections. Yeah, well, not all infections, some of them. And so when a susceptible becomes infected, they can either move to the E1 class or they can be contact traced and move to the E1Q class. And then what we do is we allow our infections to move along this conveyor belt from one compartment to the next. And what we do is we allow them, so the E1s correspond to infected but not symptomatic and not transmissible. E2 corresponds to pre-symptomatic and transmissible. I1 means you're starting to, you might be showing some symptoms and you're at a higher level of transmissibility. And then when you're in the I1 class, then either you show that you're sick or you don't. If you're asymptomatic, then you continue into I2. If you're symptomatic, then you'll continue into the MQ class, which is mitigated. And so those individuals, we will assume then that when they reach the M and the MQ classes, then they're moving into some self-isolation within their home or within the hospital setting, depending on how severe their symptoms are. And then we have all of our removed classes here, and that can include death and recovery. So within this EPI model, we apply different public health mitigation strategies. So I talked a little bit about contact tracing, but what we can do is we can change the rate at which individuals are contact traced. And we can also change the number of days of contact tracing that we can look at. Within the contact tracing, we can also change how effective it is. So we can say, suppose 80% of contacts are traced, but then maybe once they're traced, they're only reducing their contacts by 50% or reducing their contacts by 80%. So these are things that we consider within the contact traced population. We also, within the contact traced population and within the population that's not traced, but in the mitigation phase, we also assume some reduction in contacts for the mitigated cases. So we have contact tracing and mitigated cases. So here that's moving into the gray box, but then also the purple ones. We also assume on top of this that there could be social distancing and school closure and self-isolation of high-risk individuals. And so we apply that to the entire population. So within Ontario, on March, I think it was March 17th or 18th, there was an announcement that everybody was really supposed to ramp down their contacts and that only essential workers would be going to work. And so then essentially it means that the entire population had a reduction in contacts. And so we allow the whole population then to be socially distanced. And then if we're modeling children, we also closed the schools. So every once in a while, school closure was updated and extended. So we incorporate that. And then within that too, there's also announcements for people who have high risk of infection or high risk of severe infection to self-isolate. And so we also incorporate self-isolation, elective self-isolation into those populations, which would be the elderly populations and maybe pregnant women, etc. Or individuals that have specific comorbidities that increase their risk of severe infection. So that's what the EPI scenario type of model looks like. So what we do then is we apply this model over many different age groups and population strata. So we divide our population into many groups, and these incorporate 1, 2, 3, 4, 5 age groups or more, depending on how refined we want to be. We've also split the Canadian population up in between non-Indigenous and Indigenous populations because some jurisdictions are interested in knowing if there's a disparity within the infection of between these two populations. And then we also, for reasons for looking at severe outcomes, we look at pregnant women. We also have applied self-isolation to the older age groups. And then we've also separated out healthcare workers because there's some interest in knowing whether we'll actually have the the staff and all of the workers needed to be able to take care of all of the influx of other patients into the healthcare system. So we model them as well. So we stratify the population by age, by subgroup, and by risk of severe outcome. And then we also have this other column down here where we have a probability of hospitalization given infection. And this probability is informed by data within the Canadian and Australian and British contexts, where I'll also mention that there's somewhat some hand waviness calculations within these two age groups, because in Canada, when someone in a long-term care facility was infected, if they have a do not resuscitate order within their file, then they won't be transported to hospital if they get really sick. And so we need to incorporate some knowledge of these do not resuscitate orders within the long-term care facility and the elderly population, so that we can get a good idea of what the severe cases will be. And so this isn't necessarily the probability of hospitalization given infection. This is the probability of severe outcome given infection for these older age groups. Okay. So that was the scenario-based model, where we turn on and off and ramp up and down contact tracing and social distancing and school closure and self-isolation and so on. We also have a very simple model that we developed to fit to epidemiological data, where we're not stratifying the population by age and other subgroups. So what we thought is what we could do is try to get an idea of what the total number of infections will be given the number of known infections that we have. And so here what we have are CK, are our known cumulative infections, and this can be by province or the whole country or smaller jurisdictions that are reported. So these are reported cases. And what we do is we assume that some fraction of those that are infected are actually reported, and that depends on whether they have severe symptoms or not. So some fraction of our total cumulative infections have severe infections, that's PS, and we assume that all of these individuals are reported. But we also assume that of the cases that are not severely infected, there's a specific reporting rate R, and that has to do with testing. So here are known cases, and these known cases depend on the number of total infections, where we can also incorporate the mitigation for social distancing, etc., within our cases here. And this means that we can also factor out our reproduction number. So here, what's really interesting about this is that if we fit our model to data, we can then pull out what our reproduction number is and what our mitigation intensity looks like, given some assumed mitigation function that we're assuming over here. And we can test many different mitigation functions to see what our fits are going to look like and how that changes the reproduction number and any other parameters that we are interested in. So here are our cumulative infections and known cases, and here are here's our prevalence. So, but here is our current number of severe cases, and here are our current number of mild cases. So what we do is we assume 2 of our parameters and we fit all the rest, as well as we assume what our known cases look like for an initial condition, and then we fit our other initial conditions like IM0, IS0, and we also know what our current number of recovered cases are, because we don't necessarily start fitting the model at the beginning of when we have our first case. We start to look at it when we actually start to have some exponential growth. So the EPI model that's scenario-based is coded in MATLAB. Like I said, it has a population strata. Some parameters are fixed and some are chosen, and some vary within a Latin hypercube. So we we run many different simulations where we're varying some parameters over a Latin hypercube, and we look at the outcomes. We run the big EPI model on SharkNet, which is a shared hierarchical platform for looking at very large simulations. We also run it on PC and laptop, and the run varies from 3 to 40 hours depending on the parameters chosen. Our fitted model runs a lot faster, but it also depends on fitting error, and we don't have any population strata within the fitted model right now. But it is coded in Python, which runs pretty fast, but there also can be some sensitivities to the fitting routine. So all of our parameters have come from healthcare data and data that have been gathered by the Public Health Agency of Canada and through literature review over the course of the epidemic. Okay, so here is a look at the reproduction number for different provinces. And so what you can see is that we don't really want, well, we started fitting our model at around March 15th, when we can see some actually nice, clear data for both of the provinces. But so we fit new reported cases per day to an exponential distribution over 8-day intervals. And then we rescale the time to an infectious lifetime, which is approximately 10 days. And that has to do with this T hat. So it's not T, it's T hat, which are 10-day intervals. And then we normalize this by percentage of active cases to get a rough estimate of the reproduction number. And then that gives us where we're going to want to start fitting our data from. So we're plotting Ontario and New Brunswick because I live in Ontario and my colleague Matt lives in New Brunswick. Okay. So here is some output that we get from the EPI scenario. So this here assumes that our infection, that our epidemic starts on January 25th, but you can see that we actually don't start to get a large, any real increase until much later because there's some stochasticity in the beginning for small numbers. And this assumes that we have no contact tracing, no school closure, and no social distancing. And you'll see that for our different age groups and our different components of our population strata, what the outcomes look like, where our blue, green, like our thicker solid lines are our populations, and the thinner brown, more brown lines are our simulations that we average to get these thicker lines here. So that's without any mitigation. And then with some mitigations, you can see here that we're between 100 and 150, or we're getting our peaks. And when we incorporate mitigation, we slide that to a later time point, and we actually get a reduction in our infections. So we go from like 9 times 10 to the 5 to 4 point something times 10 to the 5. Okay, and this here has contact tracing. It has school closure for 30 days and social distancing for 30 days. So something that's really interesting, and this is a newer result from some of our analysis of our simulations as we're writing up our study, is that what we've actually seen is that when we look at contact tracing versus social school closure and social distancing, we're really trying to see what mitigation strategies really dominate. So on the left-hand side here, we have cases where we have no contact tracing, and the green means that we have no school closure or social distancing. And then the red lines have school closure until September 1st and 4 months of social distancing and self-isolation of the high-risk populations. And this is either reducing 50% of contacts or 80%. The black lines have 2 months of school closure and social distancing reducing at 50% and 80%. And the blue lines have 2 months of school closure and 1 month of social distancing at 50 and 80% reduction in contacts. And so what we can see here is that so first, let's look at this, where if we have no social distancing and we have school closure, we have no contact tracing, and we have school closure and social distancing, what we actually see is that when we implement our mitigation function, if we have a social distancing reduction in contacts of 80%, we have this decrease. And then when the social distancing is relaxed after 1, 2, or 4 months, that's when we start to see an increase. And this is the 50%, where 50% is just not sufficient in having decay in our cases. But what we also see here is that if you look at this red line, this point here is when we relax social distancing. But this point here is when we relax school closure. And you can see here that school closure, which is the reduction in contacts of just school-age children, really doesn't have any effect in what this curve is doing. Once we turn off social distancing, school closure is not really having any effect, except that what we haven't incorporated here is that if there's school closure, then parents and grandparents or family members are likely to be staying home and socially distancing while there is school closure. And so this coincides with some of other modeling study results that school closure, the main outcome of school closure is not just protecting. Of course, we're protecting children from infection, and especially children that are at severe outcome of infection, but school closure is also reinforcing that social distancing within the adult population, which we can see is very effective in reducing contact. So the other part that I wanted to compare here is that we have no contact tracing to contact tracing. And so you can see here that our peak decreases in height. You can see that the axis labels change. And our peak is shifting to be later in time. But at the same time, our epidemic gets quite a bit wider in duration. And so our attack rate and cumulative attack rate or clinical attack rate are decreased, the duration of our epidemic changes. And what you can see here too is that if you're looking at school closure and social distancing, really nothing changes except for that there's a delay in the peak. The attack rate, the clinical attack rate, and the duration are all the same. So contact tracing gives you a reduction in the peak and a wider duration, and so it reduces your attack rate. But social distancing delays the epidemic, it makes it later, and the peak later, whereas school closure has a minimal effect. Okay, so for the fitted model, we also fit, so here's Ontario and New Brunswick. We fit the black data points to the known cases, which is the green line here. And then the red data points are points that we just use to see if our fit is going along a very similar trend to what the actual known cases are. And so here we have Ontario. These are known cases. This is the total number of infections, cumulative. And then these are our severe and our mild cases, our IM and our IS. You can see with New Brunswick that we have this rebound. And what's really interesting about the fitted model is that we can capture rebounds before we even see them actually happening in a population, which is a coincidence, but it's really interesting to know that this rebound happened, and in our data, or in what our forecasting is, and in actuality, there was a rebound in New Brunswick about this time. And there were some news reports that had to do with this rebound here. Okay, so that was using a specific mitigation function. We can also change our mitigation function to a different mathematical shape. And you can see that the data fitting, while the curves are changing somewhat, the qualitative outcomes are very similar. With Ontario, we get a kind of a wider peak, and it's quite flat, whereas with New Brunswick, we still get that rebound. Over here, though, it's a lot steeper. Okay, so remember that that when we were looking at that simple fitted model, we had a parameter of the reproduction number. And so with our fitted models fitting to the data, we can actually get an outcome of what the reproduction number is going to look like. So we can calculate our effective, and you can see that from the fitted model that we can get an idea of what this looks like over time. And what we do is we get a changeover from above 1 to lower than 1 sometime in May, which is agreeing with quite a few other models and what actually happened or was believed to have happened in Ontario. And with New Brunswick, it actually happens quite a bit earlier, where they had a lot less cases. Okay, so now that we have these epi curves, these are all of this is our patient data, we can use that data to feed into the healthcare demand model. So we split our cases into mild and severe. And then what we do is we have our severe cases present to the healthcare system. Some of our mild cases present. And if they can't actually get an appointment, then they are sent home, and then they try again the next day, or some fraction of them do. But we also allow them to try many different instances within the same day. And so we can have them say, go to the emergency department. And if the emergency department can't see them, if they can't get a consultation, then they try for their GP. And if they can't get a GP consultation, they go home and they call telehealth on the phone. So they always actually do get some feedback during the day. We also do it where if they have assessment clinics, if they can't get an appointment, they go to emergency. After emergency, they go to the GP, and so on. Then what we do is, if they're going to be admitted to hospital, we first determine whether they need an ICU bed. If there's an ICU bed available, then they get it, and then they populate that for a certain number of days. If the ICU bed is not available, or if they don't need one and there's a ward bed available, then they populate that and they stay in that for a certain number of days, where these days can change depending on what the data is in the jurisdiction that we're studying. And we can also allow people to go from ward to ICU and back, and so on. We also, if all of our hospital beds are full, then individuals are sent home, and we can keep track of that as well. So part of modeling this healthcare demand flow is also requires some understanding of what the healthcare system looks like in the jurisdiction under study. And so by jurisdiction, what we do is we assume that the number of GP consultations available each day for COVID-19 cases is about 50%. Our emergency doctor consultations for COVID-19 are at 50%. If we have an assessment clinic, then it's 100%, because the assessment clinic's just for COVID-19 patients. But we have to populate the people who work at those assessment clinics, and we have to pull individuals away from the general practitioners and the emergency doctor pools. We have a function that we use to do that. And then we also assume that for our ICU beds, that the availability is at 50%, as well as the ward beds. Okay, so we do allow individuals to present to the healthcare system early versus late, and we separate that for our severe cases. We also do assume that if an individual even gets an appointment today, like a consultation with their GP, then tomorrow there's a specific probability that they might also present to the emergency department, depending on some roll of the dice. And that just allows for the disease to become more severe. We also assume that some fraction, if you're looking at the proportion of severe to mild cases, that the proportion of mild and severe cases that present to GP versus emergency doctors versus assessment clinics is different. And we also assume that that there's a capacity to which the consultations are, as well as the beds. And so here we had to gather data at the national and provincial and territorial level of the number of ICU beds, ward beds, and general practitioners and emergency doctors, where then we had to then go and calculate how many, given we have, say, 30 general practitioners, how many consultations are available each day from general practitioners. And then we divide that by 50% to get what's available for COVID-19 patients. This is information that I already said before. So then what we do, so as those individuals go through that healthcare demand flow, we then keep track of the number of consultations each day in each jurisdiction, each healthcare setting, and we keep track of how many ward beds and ICU beds are populated every day. And then what we do is we take all of that data and we determine what the demand is going to be for personal protective equipment within each setting. And so here is a chart of what a personal protective equipment set looks like in different healthcare settings. And this is from a study by the University of Toronto. And you can see that different sets of personal protective equipment are have different items within them. And so here you might have a surgical mask, whereas for a different set, you're going to have an N95 mask. And so what we decided that it's kind of difficult to keep track of these sets, and also given that within the healthcare settings, these aren't exactly what the sets are going to be used in practice, because there are limitations to the and resource limitations to the number of items that a healthcare setting will have. And so there could be trading for different items, like there could be a trade of a surgical mask being used instead of an N95 mask in some cases. And so what we decided is to just project what a PP set would need to be in each healthcare setting. But we also assumed that the PPE set is going to be different for a background worker versus a doctor or a nurse. And so you can think that when you go to the doctor's office, there's a receptionist. The receptionist won't necessarily be wearing a gown and a face shield and gloves and a mask or N95 mask. Maybe the receptionist is wearing a different kind of gloves and a surgical mask. And so what we do is we keep track of what the sets look like for the background workers as well as the doctors and the nurses. I'm going to skip this. This is just really just determining what our number of consultations are going to look like, depending on what our usage will be as well for our personal protective equipment under different usage scenarios. So we do calculate what our PPE sets are going to look like under a conservation scenario, a moderate scenario, and a high scenario, where we have lots of changing of our personal protective equipment every time you see a patient. So we summarize our PPE requirements into 4-week blocks, and we can actually get a lot of information out of this workflow. So this is looking at the scenario-based model, where we can get an attack rate, a clinical attack rate, duration, peak size, and so on. We can also get what the total number of cases are going to be that need that ICU and the ward beds, and we can determine that when we don't have assessment clinics, which is default, and when a province opens up assessment clinics. So you can see here that certainly when you have an assessment clinic, you're able to see more patients, and so you actually service a lot more patients within your ICU and your ward beds. Okay. We also can look at what our total number of cases are that are going through the assessment clinics, the emergency doctors, and the GP offices. And we can look at what the peak demand is, and we can also determine the number of people that have been turned away. So we can look at the excess demand. And so that goes along with, so in China, one thing that what happened during the outbreak is that they opened up, or they built new hospitals. And so, and something that's of interest is to determine whether if we decided to add a bunch more ward beds from a certain ward in a certain hospital, instead of using it for some other healthcare needs, then how many more patients are we going to be able to service over the course of the epidemic, so that we can reduce our excess demand. And then you can go into an economics type of discussion to look at the qualities and the DALIs depending on the number of new beds opened per day, etc. Okay, so moving to the personal protective equipment, we also have a conservation, moderate, and high use scenario, and we can also determine the number of PPE sets that are needed within each jurisdiction under default when there's no assessment clinics and when there are assessment clinics. So we have lots of data that come out of these simulations. And I'm going to skip over some of that data and just move straight to looking at what our 4-week blocks are going to look like. So this is our projections of what our PPE needs are going to be over all of the healthcare settings. And these are our PPE sets, and this graph down here is we've separated out the N95 masks to see what their demand will look like, because there's higher demand for the N95 mask than some other items within the PPE set. Okay, and finally, we can do the same thing for our fitted models. We can we project here, so this is the background usage that we need. And this is our N95 masks over the course of the epidemic for Ontario. And we can also get information for province like New Brunswick with very little cases, but we can get some usage for background usage at least that we need for our personal protective equipment within all of the healthcare settings. And we just project those by 4-week blocks. So month by month by month, we determine what's going to be needed for all of the hospitals, etc. So those are the things that we have done with this code. I told you at the beginning of the talk that we are also extending this to look at long-term care facilities, vulnerable populations. These are populations that we're considering extending the work to, social work, other government institutions, as well as, instead of just looking at the provincial level or the national level, we can bring this down to smaller regional levels like county or city and so on. We also are currently modifying the code to look at de-escalation. And so as we allow people to turn off social distancing, it's not right away one day and then everything's back to normal. Things are being ramped back up. And so we're incorporating that. And we've also discussed adding influenza into the simulation to see how that's going to affect needs during the flu season. But also what's interesting about this workflow is that we can incorporate any epidemiological model into the workflow. So that first thing, the scenario-based or the fitted model, we can take those out, and what other provinces and have been doing is they've been sending us what their code generates in terms of the number of cases, and then we can use their data from their code to flow through our healthcare demand and our PPE modules, so that we can give them projections of what their demand and what their needs are going to be in the future. So this work is in collaboration with Matt Betty, who's an assistant professor at Mount Allison University. The code, I told you, has been adapted from colleagues from Australia at the University of Melbourne. And I'd also like to thank the Public Health Agency of Canada, who got me started on this project. And this has also been in close collaboration with Health Canada and Statistics Canada. So I'll thank you there. And if you have any questions, I hope that there's some time for that.
Hello. Hi. Hi. Thank you very much for this very interesting talk. So we have now time for questions. So remember, there are two choices. Either you can write on the chat, or simply unmute your microphone and please ask directly. Let me put the thing on the chat. Jorge.
No, I'm here. Control. Wait.
I have a question.
Go ahead.
At the beginning, some of your results showed that school closing was not influencing anything. Isn't that counterintuitive? I mean, with respect to the evidence of Israel. I think it was in Israel where, I mean, after closing schools 2 weeks later, reopening schools 2 weeks later, they got a peak.
Yeah, so there's a lot of discussion about that. I think that, so when I was discussing that figure, so I'll go back to it. I was really looking at how, when I talk about school closure, I was talking about how we're only looking at reductions in the contacts of the school-aged children. But when we have school closure, that also means that parents have to stay home. And so I think really when you have school closure within these simulations, it's really reflecting the fact that if parents have to stay home, then you have some social distancing that's still happening. And that's why you are able to maintain a lower level of cases in overall, because the older age groups are social distancing. Whereas when kids go back to school, then parents relax and they go back to work, or things like that. And so perhaps the outcomes of what has happened in some countries when school has gone back in is really a reflection of the other age groups relaxing too much. That's just a hypothesis that I have, but that this is just what this code is showing.
Thank you.
Thank you, Luis. Any other questions? Let me see, there is a question here. Nancy has a question on the chat. Maybe Nancy, you want to directly ask the question, or do you want me to read it? Just unmute your microphone.
Okay. Can you hear me?
Yes,
Yep.
we can.
Okay. Well, thanks, Jane. I just want to ask you, how long does it take to see the effect of contact tracing in the number of infections? How to measure this delay in realizing the effect of this?
Sure. So we, when we implement contact tracing in this model, we do it right away. But essentially so in Ontario, it was kind of ramped up. We haven't incorporated a delay here. And so when we implement our contact tracing, it's implemented right away to full efficacy. But we can change the way that we model it so that it ramps up, or so that it depends. But I mean, our contact tracing does depend on the number of cases. So there's at least that component. It's not just turned on and off. We actually have a function that determines what our contact tracing levels are going to look like dependent on the known cases. But in this simulation, we turn on our contact tracing right away at the beginning of the epidemic. We haven't actually looked at turning it on later. So I can't really answer that question very well.
Okay, well, thanks, Jane.
Thank you, Nancy. Any other questions? So if not, okay, shall we thank the speaker? I'm a classical guy, so I like to, you know, applaud, yes, and mute the microphones, and we do it in the standard way, please. Thank you very much.
Thank you. If anybody has any questions about some of the things that I skipped over, feel free to send me an email and I can try to explain some of the things better. I knew I was running out of time, so I couldn't go through a lot of the results and the healthcare demand very well.
Very good. Thank you very much, Jane, and thank you, everybody. So, Jorge, do we have some announcements for next week?
Next week, I don't remember who is next week.
We have a seminar, yeah. We have Alexei Kachenko, if I recall correctly, from Brookhaven National Lab.
Okay.
And I don't remember the title of the seminar. Something like COVID modeling from the micro, meso, and macro scale, or something like that. Yeah.
Okay. Well, see you next week then.
Yeah. See you next week. Thank you, everybody.
Thank you very much, Jane.
Thank you.
Thank you, Jane.
Have a good
Thank you
night.
very much. Bye bye.
Bye.